Welcome to this talk, and Professor Robert Clancy's kindly agreed to come back. Always popular. Professor, thank you so much.
It's really good to be back with you, John.
Now, you're actually, you're just completing a trilogy of 3 new papers, rethinking your ideas about the airway immunity. Now, to give people background who aren't from a clinical background, every winter we get a complete onslaught of patients in with exacerbation of chronic obstructive pulmonary disease. And, this is a big contributory factor to the winter bed crisis, and people have so many respiratory tract infections. So, and this is really this is such a big problem. And yet the thinking on it hasn't really moved forward in arguably the past 20 years, really. So you've been rethinking your ideas on airway immunity. What's your initial thinking on what are you rethinking?
Right. Well, I think by background, John, I'll just make a couple of comments. First of all, it's wonderful to be back. I'm one of your great supporters. I think you've contributed so much to the world in terms of understanding not just COVID, but a lot of things around it. And I guess in a way, I've always tried to learn from experience, and it's quite interesting. As you well know, I've written a number of articles for a very excellent journal that comes out monthly here called Quadrant. And I couldn't believe I've written 15 articles over the COVID period.
Yeah.
And you're very kindly offered to do a preface for it. Well, it's finally on the cusp of actually coming out. And I mean, not that I've got any great insights into much, but what I find interesting is that it's one person's look at learning through COVID, because I made the mistake of going back and looking what I wrote at the end of 2020, and I wrote with great hope. Australia had as many countries, most countries had, a plan for how they were going to cope with a pandemic, and Of course that didn't work out too well.
It's the fastest forgotten plan in history, wasn't it?
Yeah, it was a planning misadventure. But the interesting thing is that I noticed that I fully weighed into the best of what we could do, and then suddenly found that things weren't working terribly well, and fell apart because people didn't take notice of what we should have known, what we did know, and what we were learning in those early days. And so this book is finally coming out, John, hopefully in the next few weeks. But maybe we can talk about it at some stage. But I think it's not that I can offer that much, but I think the strength of this is that it's one person looking at the change as we go through. And I found COVID a very interesting period. I mean, it was a terrible period, but it was an interesting period for me from a medical viewpoint and a scientific viewpoint, because it made me rethink a lot of the things that I'd been working on for 20 or 30, sometimes longer period. And you referred to a couple of papers I sent to you. These were essentially putting together what I've learnt from COVID. COVID was, hopefully for all of us, a learning process, not just in terms of how we could have done it better in terms of treatment, how we made some massive mistakes in taking the wrong route for vaccination, how we didn't base our whole approach on trying to understand the epidemiology, the spread, the mechanics of the disease, if you like. And but I learned a lot about my own area of interest, and that is how the airways react and respond to infection, which is what I've worked on for many years. And as a result of that, I put together 3 bits and pieces, which may or may not ever see the light of day, but hopefully they will. The first one did, and the second one's in the process of, and the third one's about to be sent off to a journal that never ever published anything I'd ever write about COVID, because that was not kosher. So the first of those, John, was an article that I wrote for vaccines, which is a prominent journal in my area of immunology, and it was essentially written as a 50-year overview of what's happened in how we understand how the lungs work and how they react to infections. And the driving force when I started writing the first paragraph was that two very close friends and two very good co-workers of mine, my boss in Canada, Professor John Bienenstock, and my very close colleague in Australia, Alan Cripps, had sadly died in the year before, which was 18 months, 2 years ago. And I wrote this more or less as a memorial for them. But as I wrote it, my idea of where we went wrong in trying to vaccinate people with messenger RNA vaccines sort of evolved. And it struck me that we were taking a very wrong approach. We were trying to immunise against an infection that came in through the nose, through the mouth, and for most people stopped in the respiratory tract. And we were injecting a vaccine that stimulated immunity in the bloodstream. And there was a sort of barrier between the two. Now, there's no question that vaccine would stop the virus escaping into the internal part of the body, and as such would prevent, at least for a period of time, a short period of time, severe infections requiring corticosteroid treatments, perhaps going to hospital, quite major innovations. So it would do that to an extent for a period of time. And we still don't know how big that extent was because it got outweighed by damages that the vaccines did. But that's not the story for tonight. So I said to myself, why is it that you see 100 patients with COVID, and of those, 95, 96 might get anything from a sniffle to a cough, maybe sick for a few days, but like a bad flu. They certainly didn't have their lives threatened. 2 or 3% got very sick, and 1 or 2 might go to hospital, and if you're very old, then there's a chance you might die from the condition, particularly if you've got collateral heart and lung diseases or diabetes or other collateral disorders. Yeah. And so I asked a very simple question: why is that so? Why? And then I looked at what I'd been and my group had been working on for many years, and we'd been working about the way in which the lung gets its protection. And it doesn't get its protection by making antibodies from within the lung so much. It actually gets it off-site. And we have talked briefly about this, I think, in the past, John. We have. But,
it's worth going over again, though, Robert.
Yeah, it took more meaning, I think, when I started thinking, well, all the work we've done is in people with quite serious disease, chronic obstructive pulmonary disease, COPD. People are often who, in the last year or two of their life, with quite sickness, living in fear of getting an infection. But I started saying, well, why is it then people who are relatively well, most do well, some do not do well when they get the flu or they get COVID. Yeah. And it struck me that you have to understand that in terms of the mechanism whereby the lung is protecting itself. Some people protect themselves well, some people do not protect themselves well. And so we look back at studies that we've been doing in people, for example, smokers. If you look at smokers, about 20-25% of everyone who smokes will go on and get COPD. You know, it's a big risk, smoking. Yeah. And the question is, why is that so? And then so we looked at people who were established smokers. We found about 25% of them were completely unable to prevent bad bacteria coming down from the mouth area into the lungs, creating what we call a dysbiosis, a disturbance of the normal protective microbiome. The good bacteria got replaced by bad bacteria. And so much so that we could show that in that 25% of people, they were leaking the bad bacteria, not just in the mucosal compartment, the inside of the airways, but into where the lung is doing its job of putting oxygen into the body and taking carbon dioxide out. So this was
right down to the alveoli.
Exactly. This was threatening the integrity of the body. It was exposing them to a danger. And if we made this protective mechanism more effective, because we then worked out what the protection mechanism was, and that is that instead of making the antibody, it wasn't antibodies, it was the T cell. Remember, I think years ago, John, we talked about the two arms of the immune response, the antibody and the T cell. Surprisingly, the antibodies didn't play a big role. The T cells do. And what the T cells do, they don't come from inside the lung. They come from over here in the gut. And in the lining of the gut, there are little factories. And these factories are called Peyer's patches. Now, some of you might have done biology and anatomy in university or school even, and there was always these funny little knobs in the small bowel called Peyer's patches. You remember them, John?
Oh, yeah. I remember being taught they don't seem to do very much.
We didn't have a clue. We just were annoyed that we had to learn yet another name.
It's a bit like an appendix. We didn't really know what it was for.
No, we didn't. Well, I didn't work out what they're for. A chap called John Seabra did that some years before, just before John Benenstock and I started working together. And what he found was that they're the factories for making immune cells. He made it for antibody. Later, my group in Newcastle found it was also for T cells, particularly for T cells that will travel from the gut, from the small bowel, through the bloodstream and land in the lungs to protect them. So the lungs had this very clever mechanism of protecting itself without actually using up the energy of the lung itself. It parked it over here. But how do you stimulate it? Well, you stimulate it by swallowing your sputum. We're doing this terrible thing. I hope everyone's had their dinner or their breakfast over there. Getting a new prime minister, I see too.
I believe so. Yes.
Well, I don't think he's going to be missed too widely. But anyway,
no, I don't think so.
For a non-politician like me, So what we found was that the way in which the Peyer's patches, these little factories in the small bowel, made the T cells that would go through the blood to the lung, is you would swallow the bacteria in the sputum, and this became a large number because you're getting this infective process going on from the virus, and it would stimulate the factories to export their T cells, and the T cells would have little receptors on them, which we now know about. We didn't know about that a couple of years. We knew they probably had them, but we now know what they are. And these very specific receptors, I call them postage stamps, say, take me to the airway. But we found that in about a quarter of the people who are chronic smokers, they didn't make these T cells very effectively. It's a pretty fragile process when you think about it. You've got to make the bugs, you've got to take them up, swallow them, get through the stomach where the acid will destroy some of the bugs, and then get down into the small bowel. And so what we did is, it wasn't a big move. We just said, okay, let's grind up some of these bugs, kill them so they're not going to cause a problem, put them in a little in a tablet, and swallow them and see if we can make the process work better. And it did. And all of a sudden, now let me see if I can explain this. What you're looking at here is antibodies in blood against this particular bug called non-typable Haemophilus influenzae. And if you look at two groups of people here, they're all chronic smokers, but half of them have been given this super ground up bug as you like a medicine, if you like, by mouth to make their process work better. And the other half have been given dummy proteins. And this is quite a big study. This is 64 smokers. So it was a serious and large study. Now, immediately you can see a massive difference. You can see running along a dark blue line with tiny little, what we call standard error bars. In other words, over the period of time, and you can see the visits go over 3 months, 2.5, 3 months, there's absolutely no change in the level of antibody in the blood. And these are the ones who were given the oral super duper extra bugs that to make the swallowing process work more efficiently. Now, you can see what you're looking at is on the vertical axis, this IgG is the antibody level. Now, that IgG antibody is only going to be made in the blood if the bugs in the mucosal compartment, the airways of the lung, leak out into where we're trying to do the business of oxygen and carbon dioxide exchange.
Yep.
So if you're going to have that happen, then you don't want bugs leaking from the bronchial passages into the gas exchange apparatus of the lungs. If it does, then you start making a vigorous IgG antibody. Now, you don't see any of that when you've got a lot of the stimulus for the Peyer's patches being swallowed. However, if you look at the placebo group, these are the ones who got the dummy tablets with no non-typable Haemophilus influenzae in them. That's the purple one. It's all over the place. Not only is it increased, but those standard error bars are massive. Now, when you analyse this, that major change is only occurring because 25%, 1 in 4 of the placebo group are the ones who are not containing normally and naturally the abnormal bugs in the mucosal space. So what this is showing, it's the most dramatic change I've seen in any study we've ever done on mucosal immunology. It is a dramatic demonstration of how, firstly, in people who are smoking at risk of getting airway infections, serious infections, chronic airway, COPD, chronic obstructive pulmonary disease, these people, we know that about 25% of them will get it. And lo and behold, 25% of the smokers, before they get their COPD, are leaking these bugs, the bad bugs, causing all sorts of inflammatory changes, which we know can progress in some people towards permanent damage. So this was very exciting. Now, you can see these little yellow triangles at the bottom. That's when we give our oral non-top. We give it once a month. So visit 1 at the beginning, visit 3 is 4 weeks, visit 5 is 8 weeks. And so we're giving little pulses as though they're swallowing this from getting a natural infection, but they're doing it extremely efficiently by protecting them from the acid in the stomach. So that was the first idea. That it came out of COVID. I would like to think I'd think of this anyway, but I have to say that when I started thinking a lot about COVID, as you and I did that 4 or 5 years, John, I kept asking this question, why? Why is some people getting mild COVID, most people getting mild COVID, but some getting bad COVID? How can we explain that? And so we started looking at differences in the mechanism of protection and what we can do about it. And of course, where this goes is that the simplest, cheapest, safest way of protecting people may not be the vaccines, which have a pretty sad record, but rather changing the whole way in which the airways will react to any infection, be it flu or COVID or RSV, rhinoviruses, any of these viruses that you might breathe in. So you make the airways more resilient. And so we developed the idea of what we call respiratory resilience as being perhaps one way of looking at going forward in protecting people against getting serious airway infections.
And of course, this would upgrade the mucosal immunity against all airway infections. Big problem with the vaccines is, apart ignoring the side effects for a minute, which is hard to do, but if we do that, they're only upgrading the response against one specific viral antigen, whereas this is upgrading the entire immune system. So basically what you're doing is upgrading the innate, non-specific immune system that's going to work against a wide range of organisms. Is that correct?
Yeah, that's exactly what's happening. We're resetting the mechanism, and to do that, we drive it specifically by giving a particular antigen, the commonest bug that is produced in these dysbiotic circumstances, and that stimulates a specific change. So the T cells that are coming from the Peyer's patch across to the lungs are highly specific. But once they get to the lungs, they go into the business of activating the non-specific protective mechanisms, the white cells that will gobble up bacteria, the various chemicals, cytokines that can neutralize various aspects of a virus.
Right. So you're going to get more macrophages and neutrophils.
A response to a non-specific one. Non-specific meaning that no matter what that virus or pathogen bacteria that's breathed in, then you'll get a higher level of response. You're shifting the response from serious to less serious disease. A lot of inflammation, very little inflammation. Containment, non-containment and leakage to containment of the pathogen to the mucosal space.
Away from the alveoli, because of course if the alveoli get filled up, that by definition that would be a pneumonia, wouldn't it? Really,
that is pneumonia, and what you're trying to do is protect against the pneumonia. Keep the bugs where you want them, where you can cope with them. Don't let them leak into the business part of the lung, which is the alveoli, the gas exchange part. Exactly.
So the problem is that this is not being used. I find it inexplicable. We've got the evidence in front of us here that we're looking at, and yet this isn't used in every hospital in the world. I mean, what's stopping this mass rollout? Because this is so brilliant.
I've got to take some blame for this. Our approach to this is it did not begin as trying to develop a medicine or a particular way of protecting people. I was interested in how the lungs worked. I was interested in, if you like, the physiology, and we decided to. I started work with John Bienenstock way back in the mid '70s, and John had this idea that there was a communication between the different mucosal sites. Before then, everyone thought of the gut and the lung and the reproductive system all as having their own separate bits and pieces, and really the immune system hardly counted. It was not given as much credit as it should, and we may well move on to that, but that's the way people were thinking. And I'd just arrived, I'd finished my PhD in autoimmune disease. I'd done my internal medicine exams back in Australia. I then went off and did a PhD in Monash University with Barry Firkin on idiopathic thrombocytopenic purpura, an autoimmune platelet disorder, because I wanted to be a clinical immunologist, which is eventually, I guess, what I became.
You certainly did.
But clinical immunology didn't exist.
No, you had to invent the field, didn't you?
Well, what happened was quite interesting. England was stymied by the fact they had basically PhD lab people running the tests for immunology diseases, and they corralled clinical immunology. And the allergist would be looking after allergy, but the type of clinical immunology that the Canadians and then we developed was very different. And I went to work with John, and John was quite keen for me to set up a clinical immunology lab unit, which, as I said, didn't exist really, except in Canada it had begun. And I can remember my first day there, John. This is getting a bit teary. The great Moore and Campbell was the professor of medicine, and most people will know Moore and Campbell as the man who developed the rebreathing for measuring gases in people with lung disease by measuring carbon dioxide coming out of the lungs. More people will remember it that became adapted into a breathalyzer for police. So, so we gave Moore on a terribly bad time over that. But I remember walking into the first day I arrived, and Moore and Campbell said, "Well, Clancy, people say nice things about you, but you've got to understand that if you're in Canada, you've got to do the Canadian Fellowship exam, or we don't pay you very much at all." Not that I'd ever been paid very much at all, but I still had to, pay for where I lived and things like that. And so I had to turn around and do. I'd just done the specialist exams in Australia, thinking that's it, no more exams. And lo and behold, I arrived, and with a couple of English people, because they were in the same boat as me. One thing about Moore, and he did pay for a taxi for us to go to Toronto to do the exams. So I actually did it in clinical immunology, which first begun in Canada. And I was the second one to do clinical immunology as the exam in Canada. And when I came back to Australia, it didn't exist at all. One guy, a chap called Ron Penny, had been developing those services at one hospital in Sydney. I started the services at Prince Alfred Hospital, the other big hospital in Sydney. And we all got together, the two or three of us, and said, let's create clinical immunology. And now I go to the meetings now, John, I don't know a soul. They don't know me either, so I guess it's fair play. But
it's a pity. Times move on quickly, don't they?
It's a booming thing.
But you and me know you started it, Robert, and a few people watching as well.
Well, my background before that, I trained in gastroenterology, so I understood and was interested in mucosal surfaces.
Sure.
So when I went to McMaster and worked with John Benenstock, I was able to. I set up their inflammatory bowel disease clinic there, which is now one of the biggest in North America, because it's an immunological disease of the gut mucosa. So that's the history, and this is how it's gone, and this is how COVID fine-tuned some of those ideas into something that hopefully will become useful. But doesn't really answer your question by why everybody's not eating ground up non-typal Haemophilus influenzae. Oh, it's a long story. It'll get there. It'll get there.
It will be. I mean, this is Nobel Prize material, because the amount of human pain, suffering and death this could alleviate is absolutely astronomical.
Look, it would. But look,
I mean, every went to the surgeon.
It's a very unsexy product. I mean, it is literally killed bacteria, which went out, with the ark. And it just happens that this is the way the physiology works. The patch is not geared for a monoclonal antibody, which is patented and which you can charge, a couple of $1,000.
That's right, and it's generic. It's not a specific molecule that's patentable for 15 years. So it's made
to gobble up bacteria, and the bacteria work so well. But of course, it's
and you upgrade the entire system. Therefore, you reduce the demand for a whole range of drugs.
Well, who knows? But
maybe I got too cynical in my old age, Robert.
No, I think that's the worst thing about COVID, don't you think, John? That
it really is. It's really brought it to light, hasn't it? There's a lot of commercial racket is involved. Your idea and Gustav Gleicher's idea are very similar. You can both massively upgrade the immune system.
Yeah, well, Gus has taken actually not a totally dissimilar approach. Gus's view. I'm looking at infection, he's looking at cancer. Both of them have on their surfaces distinctive markers called antigens.
I think he's looking at infection as well. He's looking at just upgrading the whole T-cell immune response.
He's giving a non-specific stimulant, which makes the innate immune system work more efficiently.
Yeah, he's upgrading the systemic immune system, and you're upgrading the mucosal immune system. The two... if you upgraded both, you would. Life would be a lot better for a lot of people. I mean, I think you should co-win a Nobel Prize, because I think it's coming at a similar problem from two ends. I really do. It's
no, it doesn't work that way, I'm afraid.
Well, I know it's a pity. It should do.
I started the clinical immunology unit at Prince Alfred. I think I'm about 2 or 3 years old, a couple of years older than Gus. He'd probably say I'm 20 or 30 years older, at least in thought processes. But Gus actually arrived and worked in my department literally about 6 months after I left it to go to Newcastle, where we started a new medical school. So we nearly crossed in. He married an Australian, so that's always a good thing.
And he flew aeroplanes around the outback. He was a flying doctor for a while, wasn't he? He actually flew the aeroplanes himself. Quite incredible.
Well, he was working with the flying doctor service for a while. That's true.
Amazing. What evidence have you got that there is linkages between the gut mucosa and the respiratory mucosa? I mean, if you stimulate the gut microbiome, how do we know that can benefit the respiratory microbiome and the mucosal system?
Well, that sort of
mucosal immunity.
Yeah, I said there are three things that I started thinking about, and the first was we've just talked about. The second was that COVID made me think again about the way in which various people were finding that when people got COVID, they got a dysbiosis, a disturbance of their microbiome in the airways, but they also got one in the gut. Now, how could that be? And then some clever people started finding that in the people who got post-COVID illnesses, they still had this dysbiosis in the gut. And if they treated that dysbiosis either with particular types of probiotics or by replacing with what we call fecal microbiome transplantation, that is washing out the content of the bowel and replacing it with a normal content. It sounds pretty awful, and but it's incredibly effective for a number of conditions.
I mean, we've both seen dramatic cures in you much more than me, but under Tom Brodie, I mean, quite amazing.
I still do a clinic I'm a great sadist. My friend and colleague of 30 years, Tom Brodie, died just last year. And
this discoverer of the Helicobacter pylori.
Yeah, he did. He discovered the cause of peptic ulcers.
Yeah, he should have got the Nobel Prize. Co-won the Nobel Prize for that.
Tom was an amazing guy.
Yeah, he was. I only met him once, but it was quite a memorable experience.
Well, I met Tom 30 odd years ago because I wanted to put a laboratory into an active gastroenterological group, and no one in Newcastle was too keen where I was. I was working at the university there, so I spoke to my old mentor, my old teacher, who said, "Look, go along and talk to this guy called Brodie." I looked up Brodie, went out to his where he worked. He had this really a very sophisticated clinical setup, and he said, "Right, well, we can do that, but here's the deal: you've got to come along and do a clinic on Fridays for me." So 30 years ago, I started coming down to Sydney on Friday.
Still do
gastroenterology clinic. We're converting it gradually into a bit of immunology.
And I came with you to one of those. It was really very interesting.
We set up this laboratory in his clinic. It was quite a sophisticated lab, and what we did is Tom would always be doing biopsies of people with Crohn's disease or ulcerative colitis, and he'd just take another little one. It was all done through the ethics committee. Only tiny little harmless things. We'd put it in a tube, grow them up in an incubator, and then send it up to Newcastle. I had 2 PhD students at the time measuring cytokines and all those clever things that immunologists do. And it really changed our understanding of peptic, of the way the body responded to Helicobacter. We were able to identify what was wrong with the body's response, why they would get different patterns of peptic ulcer. And then when peptic ulcer disease disappeared, which it did because Tom discovered the triple therapy for it, we moved on to Crohn's disease. And we were able to find some very interesting and very important observations about the way in which the mucosal immune system was distorted in Crohn's. And that's something that if I can live another 20 years, no promises, then that's certainly what I would like to move on to, because I know that the type of treatment we were just talking about is very likely to be able to influence outcomes in Crohn's disease, but that's another story.
So basically we need to target the dysbiosis, Robert, don't we?
Yeah, I think that, just to complete that second story, what we found in COVID wasn't just the fact that the bowel microbiome was dysbiotic and also the airway. But if you changed one, the other one changed with it. And some very clever people started working on mice and in humans, and corrected the dysbiosis in the bowel, at the same time correcting the dysbiosis in the airways. And people got some improvement in some of these post-COVID syndromes. But other people, and the Chinese have really taken in Hong Kong have really taken a great lead in this. We must take our hats off to them. They've worked very hard and shown that in people with COPD, the same thing happens, that the dysbiosis in the airways is paralleled by dysbiosis in the gut. And if you fix the gut one, you can actually improve lung function, be it in a mouse model for COPD or chronic obstructive pulmonary disease, emphysema, in humans. And so all of this said to me, well, this idea that there's a gut-lung axis, because people started describing what they were seeing as a specific axis, didn't make sense to me. It made more sense that there was a continuous microbiome, modified by need as you go through in different parts, obviously looking different, but essentially continuous. And you had this continuous immune system. And at the same time, we'd been showing how powerful the mucosal immune system is in changing dysbiosis in the airways, that it made sense to me that there was a common network, if you like, a mucosal network. And so the second paper, which is currently hopefully about to be published, is looking at moving the ideas of mucosal immunology and mucosal protection from where it is at the moment as a whole lot of segments that can occasionally talk to each other to actually a continuous single system where you get communication in between. And the practical outcome of that is that we can start changing our way of therapy. So in other words, if we do an FMT, a fecal microbiome transplant, and Tom Barodi, by the way, if we didn't mention it, was the first to do this in a proper fashion in the world, as well as his triple therapy for treating and curing peptic ulcers. He probably should have. I think he should have shared the Nobel Prize. But
definitely, yeah. I mean, I've actually visited the lab where he prepares the FMTs.
You have. You've seen some of my patients there. Yes, exactly.
And it really is quite a civilized therapy. Basically, it's just a capsule that you take. The fecal donors are completely screened and it's prepared
through an enema. There's different ways of doing it, but but of course, it doesn't always work 100% and for a long period. And so, if you think of this as a single system, then we can actually provide an oral capsule containing the right sort of bugs to reinforce the immune response so that you don't get regrowth of the pathogens, the bad bacteria that was causing whatever it was, ulcerative colitis, C. difficile, the various conditions that we treat for Crohn's disease that we treat with FMT, and we can do it more efficiently. And so,
presumably, that would be even more efficient if you included prebiotics.
Exactly, and that's what we're looking. In fact, I've got a meeting at 8 o'clock tomorrow, Wednesday morning, looking at along these lines.
I thought you might have thought of that already. So the combination of the clear out, the correct, if you like, soil for the bacteria, and then the bacteria from the FMT. Can completely transform the health of the individual.
What has been missed is how powerful the mucosal immune system is, and what you've got groups of people who are just looking at the microbes, and you've got other people who are just looking at the immune system in a particular organ. And it's what's happened to a lot of science. People have, because we are so clever now with our monoclonal antibodies. And with cytokine measurements, messenger RNA, all of these various clever technologies, we forget the big picture. And so I'm old-fashioned and not as smart as these kids who can measure 500 cytokines. So I try to look at what the the framework is, so that we can then, when we're doing these incredibly important studies on the genetics and on the cell transfers, cell interactions, we're doing it within a framework of understanding of physiology.
Now, it's also because you're a general, in a sense, you're a consultant. Well, you are a consultant physician, of course, but, you know, because you've done GI, because you've done respiratory, because you've done immunology, you can sort of see the whole thing. Whereas today people specialize in, you know, we have physicians that only specialize in particular aspects of cardiology or particular aspects of gastrointestinal pathology. Or whereas if you've got this more general background, I think you can integrate. What you've actually done is synthesize areas of knowledge from, say, gastrointestinal tract and respiratory tract, and come together with one overarching explanation. That's
yeah. Well, I think
it's fortune preparing fortune favours the prepared mind, doesn't it?
Well, but this is how we used to think, John. I think that because technology, everyone gets carried away. Not that I have. Well, the PhD students I have these days are usually in historic cartography,
Right.
Pretty much. But if I have a PhD, they want to work on molecular genetics. They want to be able to measure using PCR technology or whatever else it is. They want to look at the way in which cytokine genes are being expressed and whatever, or how a particular cell has on its surface a molecule that talks to another molecule. Really important, interesting stuff.
And this, of course, is very highly focused.
This type of work has driven the monoclonal antibody story, making a specific antibody against a specific antigen, many of which have been fantastic. I mean, look what's happened in cancer treatment. I know you talk with Gus, and Gus every day will be using these checkpoint inhibitors. Rheumatoid disease, you don't see people in wheelchairs much anymore. I haven't seen a wheelchair rheumatoid for years. They're all being treated now with monoclonal antibodies and very specific therapies. So don't let me say that these things aren't important. But when it comes to the gut and to the lung, and we're using these monoclonal antibodies, we're not using them within the framework that I think the cancer doctors and to some extent the rheumatologists have been using these in terms they understand their organ. And so they're not, they make a lot of money for the companies making it, but and they are somewhat helpful. But frankly, I have to ask myself how much more helpful than a lot of the more traditional type of treatments that we had. So they certainly have a role, but they're not being used within the big framework. And that's what I think people like you and me who are outside of our 20s,
put it mildly,
we've been brought up looking at a much bigger picture. And clinical immunology certainly does that, because you cross the borders between organ systems.
Yeah. The non-typable Haemophilus influenzae, presumably it's enteric coated, Robert, is it? So it goes through the acid in the stomach?
Yes, it is. It's quite sensitive to acid, which means that some people who may be a high acid producer aren't getting enough bugs. And maybe they're the people who, if we're still looking at our curve, they're the purple ones, not the blue. So there's lots of variables that can actually make this a fairly fragile process.
It's so clever but so simple. Basically, you've got these dead bacterium in an acid-resistant capsule that will dissolve when it gets to the alkalinity of the duodenum, and that is so simple. It is gloriously simple. Is there any way is there any way that doctors can prescribe this at the moment? As it's not available in any form?
Unfortunately not. Unfortunately not. I mean, it's so crazy, isn't it? Really, that
really is.
I think one of the mistakes I've made, and it's I've got to take some responsibility for this, is that my focus, although I'm a very practical clinician, when it comes to the research that I've done over the years, it's been very much focused on how a process works. I like to know how something works, and so. And we'd always have 2 or 3 or 4 PhD students at any time, and they would be looking at a particular aspect. I was actually doing what I've just been blaming other people for doing, and that's focusing on aspects rather than...
Yeah.
And so I completely... What I missed was that I should have been saying, wait a second, we're not suddenly by accident coming up with a way of making this physiological process work better, which is what I've been saying for a long time.
Yeah.
I should have been saying, well, wait a second, the treatment for COPD isn't all that crash hot. You know, how good is, I mean, if you look at the treatment, it's inhalation treatment combining asthma treatment, which is causing the bronchi of an irreversibly obstructed bronchus to get a little bit bigger, plus suppressing with steroids inflammation.
Yep.
Now, you know, that certainly does improve symptoms to an extent. It reduces the flare-ups to an extent, but it's never been shown to actually really change the long-term natural history, because all you do, you're making the dysbiosis, which is the abnormal bacterial content, which is keeping the process going. Because most of these people with COPD have given up smoking. They realise that was causing a problem, but they still get worse. And they get worse because their bugs have changed into the bad bugs. And if you take steroids, the bad bugs get worse. So
because steroids are notorious for suppressing the immune system, aren't they?
You're not getting rid of what it is that's actually causing progressive damage.
That's right. I mean, it's very satisfying when these patients come into A&E. You give them some inhaled steroids and some bronchodilators, and the oxygen saturations go up, and you know it's all wonderful. But then, what you've actually done though is make the dysbiosis potentially worse and made it a further attack.
Right. They use more antibiotics. They got a higher incidence of pneumonia. So you're getting through that acute episode, but there's a cost.
Satisfying on the day, but completely unsatisfactory in the longer term.
So my mistake was going along with all of this. I mean, all the patients we've treated have been on whatever is the best treatment. Now,
of course.
What as you probably know, I'm not the greatest fan of Big Pharma, and what Big Pharma have done, they've taken asthma treatment and put it into COPD.
Yes.
Which is a little cynical when COPD is irreversible airways obstruction. Asthma is reversible airways obstruction.
Correct.
But anyway, you combine it with the steroid, and it does have benefits. No question about that. And so the standard treatment until, pretty much now, is what we call dual treatment. You combine a standard asthma bronchodilator, making the passages bigger, more air gets through, you get less breathless, with an anti-inflammatory, the steroid, which controls the inflammation. You've got less flare-ups, less coughing up of sputum, etc.
Sure.
But the dysbiosis is actually getting worse. Your chance of getting pneumonia is getting worse. But wait for this, John. I actually checked on this a couple of weeks ago. They've gone now from dual therapy to triple therapy.
Yes.
Triple therapy.
Giving two types of bronchodilators.
Two types of bronchodilators.
Yes.
You've got the beta agonists, what you use. And then in asthma, they've developed the antagonists of the cholinergic, the other type of auto.
One's affecting the sympathetic, one's affecting the parasympathetic.
So you put in two different types of bronchodilator.
Correct,
Now, that increases your chance of, reduces your chance of getting a flare-up by 15%. In a carefully constructed study with people liable to get lots of flare-ups, and the absolute protection is something like you're reducing by 0.1 of a flare-up per person per year. Now, guess what? In Australia, the cost of that, is to the taxpayer in Australia is just under 20,000 Australian dollars a year. And in England, you may be 10,000
per patient,
per patient. Plus, you've got more pneumonia. So, our view has been, I've had the wrong approach. I've been a person trying to understand mechanisms, and by the way, this seems to be useful. We do it, and we've done something like 8 clinical trials, randomised trials. Provided you've got bugs there, it always reduces the incidence of flares. But the mistake we made was not really doing what the big pharmas do. And we should have said, well, wait a second, we've got a treatment that is not like the current treatment. It complements. I'm not saying it replaces it, it complements it. Because all the people we treat are already on that treatment. So any improvement we see is over and above what you're getting from dual therapy.
Yeah.
And so what I'm now saying is we are now focusing on dysbiosis, the cause of the problem, for which nothing at the moment has been helpful, by making the normal control process of dysbiosis work more efficiently. So you've got improved resilience in the relatively healthy person with risk factors through to a preventative treatment where our rates of hospitalisation reduction is up to 50%. Which
I mean, in human terms, that's massive. But in financial terms, do you think the government would be beating a path to your door?
Massive. Provided they've got, they've got the bugs in the airways, and that's probably 50 or 60% of people. Not the people who have got really emphysema without a cough and they're not coughing anything up. We can offer some benefit, but only if they're young, because the older people throw in immune senescence. As you get older, your immune system drops off. But
that's physical destruction of the alveolar architecture.
Good old chronic bronchitis going on with emphysema. They're the ones who do repeatedly, reliably do well.
Yeah, your blue bloaters particularly, rather than your pink puffers.
Yeah, that's taking you back, John. And the pink puffer. You had a choice. You could be a pink puffer or a blue bloater.
That's right. Yeah. Yeah, Robert, amazing. Let's hope someone from the government's listening, because we need a relatively small amount of money and we can save governments and insurance companies around the world. I don't know, if you add this up, we're talking, I don't know, I don't want to exaggerate, but certainly, hundreds of billions, potentially trillions. It's the amount of money that we spend on this every year.
I don't understand. I don't understand it, but I do understand. Medicine's not what it used to be, John. Medicine is, and I think that this is why we've become a little cynical through COVID. I mean, can you imagine 20 or 30 years ago someone coming along with a messenger RNA vaccine saying, "Look, trust me." Can you imagine that? We had a strong medical college system that controlled what was happening. And with specialisation, we've all gone our ways. We've lost the rigour that's been applied to medicine. You don't want to have a look at the newspapers of what's happened at my College of Physicians in Australia. It brings tears to your eyes. We have these clowns that spend their life trying to sue each other. It's been really a tragic experience. That would never have happened 20, 30, 40 years ago, because we looked up the best job you could have would be in the world was to be the president of the College of Physicians, and you have trickle-down learning from that.
And trickle-down respect.
And respect. Great men and ladies, great men and great ladies.
Absolutely, yeah. No, the respect's gone. I mean, I can remember consultants saying to junior doctors, "Oh, what's your evidence for that then?"
Oh, I'll say that now, but they don't expect an answer.
No, that's true, yeah. Robert, amazing stuff as always. As soon as this, what should we say, the collective works of Professor Clancy comes out, we'd love to. No. It's well, see, it's basically the summation of your evolution of your thinking. But this is what should come out of COVID. You and like Gus, really, you're in the right position. And fortune does favour the prepared mind. So your mind was in the position where you had all this information and these decades of senior medical experience and academic research available, and you immediately applied that into the COVID situation. And the idea that for that you were at best poo-pooed and in various ways denigrated is just outrageous.
As I said, I think the milieu of medicine has changed so dramatically. so dramatically from what it was.
And the political governance of it.
I mean, a person like Tom Borody couldn't do what Tom Borody did, 30, 40 years ago.
No, that's right.
He could not have developed triple therapy for treating peptic ulcers. They'd still be mucking around doing... it's because medicine's now controlled by indirectly the big pharma companies and directly by the politics. In my country, in Australia, the headline yesterday, I should have brought it down and shown you, was that the pharma companies now are forming cartels and threatening not to bring in a lot of new medicines into Australia because our government, which probably doesn't win prizes, hopefully goes the way your government's going, it listens to these big companies and gets bullied by them, and that determines what happens. I mean, the messenger RNA story hasn't gone away. We've now got factories of these. They're bringing out flu vaccines, for goodness sake. They're getting contrived articles saying how safe they are.
And paying universities phenomenal amounts of money to write such articles.
Phenomenal amounts. They're buying my profession. Look, I'll tell you a story you're not going to believe.
But buying the journals.
The journals are well bought, aren't they?
Yeah.
And I went to a medical meeting just 2 weeks ago, and it was a gastroenterological meeting, and we were talking about treatment using monoclonal antibodies. And a guy got up, who was running the meeting, and pleaded with us as physicians to get in touch with the regulatory authorities in Australia, pleading to bring in a new monoclonal which offers very, very little, if any, real improvement on marginally done studies, costing a fortune, of course. And this is what we're getting, these little incremental changes with very little much benefit, and certainly not long-term studies.
The politicians are so stupid they'll probably pay for it.
Pleading with the doctors, the whole presentation was go out there, get in touch with the regulatory authorities, and on our behalf, we've got to get this for our patients. Mind you, the company involved happened to pay for the dinner that night.
A
few consultancies along the way.
We didn't used to let reps into the unit unless they brought cakes.
Well,
it's like an admission fee.
Yeah.
Any rep coming empty-handed was unlikely to gain admittance. But no, it's utterly preposterous. I mean, if we take that triple therapy for the Helicobacter, I mean that is just. I mean, I was in India must be 20 years ago now, and just before the eradication therapy became available, and patients were coming in with perforated peptic ulcers. These are people with life-threatening peritonitis. Some died. The others needed emergency surgery. Several a week, and we just don't see that now.
Well, for us it was several a night. If we were on call as a junior doctor, I knew that I would have at least one or maybe two people coming in with bleeding ulcers, and
and perforated ulcers.
In those days, there was a 40% mortality. It's easy one to remember. 40% over 40 would die from a bleeding ulcer.
And the agony, these patients come in with what we used to call it bored abdomen. The abdomen was so rigid because of the pain.
And when you did a surgical term, you'd get the failed medical treatment, which was quite common, and then you'd be operating on these people. I mean, the whole type of surgery was taught. The selective vagotomies, pyloroplasties.
Vagotomies and pyloroplasties,
all of the. I don't think the young trainee in surgery would possibly ever see one being done now. We don't see Helicobacter disease. We don't see.
And that's gone because Tom Brody developed a low cost single treatment.
Maybe that's the reason, but I think it's more than that. Not everyone got. And of course, the failure rate. What happened? The big company didn't want to have triple therapy.
Of course not. No, because you cure people.
They developed their own, which had 20%, 30% failure rate. So what was happening is that we were getting a whole series of people who had failed therapy, and they'd be coming to see Tom. And Tom actually was my PhD student, and Tom did his PhD on what he called saving therapy, the therapy for the people who'd failed the commercial companies' therapy.
He could eradicate the Helicobacter in virtually every case. Yeah. No, quite transformational, and of course at the time, the pharmaceutical industries were selling huge amounts of these H2 blockers, weren't they? These sophisticated anti-acid drugs.
H2 blockers would heal up an ulcer, but you'd stop the H2 blocker, and the ulcer
simply come back.
To most cases recur. Whereas with the Helicobacter, once you got rid of the bug, the ulcer never came back.
That's right, and I know people now who had this treatment 30 years ago have been absolutely cured ever since. And this is a very similar thing. You were talking about the a single immune boosting capsule that you can take, this non-typable Haemophilus influenzae, and
it's pretty boring treatment, isn't it? Killed ground up bacteria.
But you need to give it.
Very unsexy. It's it's hard to patent.
You're not taking pills every day for the rest of your life.
Most. And so, it's highly effective, safe, very cheap. But we'll get there.
I just hope you and me live to see it, Robert. I'd love to see it, but and I'd love to see you getting the recognition you deserve as well, because at the moment you're simply not. But our viewers appreciate you, which is wonderful. So, as always, really appreciate you coming on.
Well, John, I have to say, I should be very grateful. The only reason I continue practice, because I'm seriously old, is that people will not see the post-COVID damaged patients. And we are treating them now with ivermectin, and I'm not the only one. We probably one of the first, but other people now are doing this. We're about to do a big study, hopefully in Australia, using doctors who believe in this, providing their patients. So we're doing it all, a large randomised controlled trial, treating the post-COVID vaccine syndrome with ivermectin, which about 60% do extremely well. Some don't, but most do. And but because so few doctors will see these patients and prescribe this drug, it keeps me going every second Wednesday.
I wish I had half your energy, Robert. I really do.
No, you don't.
Great, as always. Thank you so much. Thank you.
It's a great pleasure, John. I really enjoy talking.
Great to talk. I always love it. Yeah.